everyone, my name is Melissa Perri and the title of my presentation is Peripherally Inserted Central Catheters During Hospital Admissions, Clinical and Public Health Considerations from Interviews with Healthcare Providers and People Living with HIV or Hepatitis C who use drugs. Thank you all for being here during these challenging times. Before I get started, I want to note that I have no conflicts of interest to declare. Today, I'll be talking about the role of peripherally inserted central catheters, or PICCs for short, during hospital admissions for people who are living with HIV or hepatitis C and who use drugs. My training is in public health and the larger team has clinicians involved, but I'm very much presenting from a social science take on clinical issues. I understand that there are many clinical considerations that are not accounted for in this presentation, and I welcome your comments during the Q&A session. Throughout the presentation, you will see the words clean and dirty that came up during the interviews with providers and patients, for example, when describing the use of clean supplies. I might repeat these terms when reading a quotation out, but I want to note that I'm not describing drug use or people who use drugs in this way. I appreciate that this is in the clinical stream, but for those of you watching who might not have experience with PICC lines, they're typically a 50 to 60 centimeter tube-like structure composed of polyurethane or silicone. They are inserted in the middle to upper arm region to access central veins and allow for the transfer of fluids or medications into or out of the body, for example, for something like chemotherapy. They are often used in cases where frequent vein access is needed or the patient has veins which are compromised or hard to access. People who use drugs are at increased risk for a range of infections, which increases their rates of hospitalization and need for a PICC line. However, there is a lot of concern about whether PICCs are safe and appropriate to administer with people who use drugs and fear that PICCs will be used to administer illicit substances. This issue is raised in the literature, but according to PICC, the evidence is not conclusive and some of these concerns might be unfounded or at least overstated. As a research team, we've been interested in exploring this further. In the interest of time, I'm not going to go into too much detail about our design, except to say that it's a multi-phase, qualitative, and community-based program of research co-led by Dr. Carol Streich from the University of Toronto, Dr. Adrian Gouda from the University of Windsor, and Dr. Sue Chan Carasone from Casey House Hospital, was funded by CIHR and the OHTM, and looks at healthcare needs of people living with HIV and or hepatitis C who use drugs during a hospital admission and the way in which substance use impacts care. Today, we're using data collected across two studies, one with 26 healthcare providers and another with 24 people living with HIV and or hepatitis C with a hospital admission in the last 5 years at the time of the study. All individuals were recruited from Toronto and Ottawa. In keeping with the qualitative approach, we're not making any claims about generalizability. Thematic analysis was conducted, and I'll share some major themes with you today. These data were collected between 2014 and 2015 and are still very relevant today. This includes, of course, COVID-19 and the impact it's had on communities of people who use drugs, the continued impact of fentanyl and its analogs, and the scale of safer opioid supply. And just on another note about language, for efficiency, we're using the language of patient and provider. We, of course, recognize that people are more than their experience of having been a patient in a hospital at one point in time. The majority of providers we heard from had concerns about giving a PICC to someone who was actively using drugs or perceived to be using. They felt that it was in the patient's best interest not to get a PICC line, even if this meant using second-line treatments, as this physician from Ottawa states, or removing the line as soon as possible, as this nurse from Toronto describes. The core issue here was fear about leaving the hospital with a PICC in place and using it to inject illicit drugs. Amongst those with concerns, PICCs were often described as dangerous in and of themselves and that they had the potential to increase infections. Overall, there were no policies about when to use PICCs or not, or when to remove them or not, and I'd be very interested to hear if any guidance has been produced since this data collection. When we asked patients about this, the majority said that they had not used their PICC lines in any non-medically indicated ways, and that, as this patient from Ottawa says, "I didn't know you could do that until they told me." Many participants told us that they first learned about the possibility of manipulating their PICC lines in the context of being threatened by healthcare staff, including with criminal charges or discharge if they used it. Many reported being too sick to use drugs during their admission, but that being labeled as someone who uses drugs impacted their care, including being told that they are being denied a PICC line out of concern for possible abuse, as in the case of this patient from Toronto. We heard from members of our advisory committee and a few of our patient participants that of course this does happen. I'd like to share a longer quotation with you from a participant who argued very strongly for the benefits of having a PICC and that in her case, it provided an additional type of harm reduction and improved her ability to stay in the hospital and receive care. Well, getting an easy port, but I also knew not to overdose. If I overdose, the game is over, right? So I don't push that envelope. I like using drugs too much to overdose. I've had PICC lines, and it made my drug use easier. It meant I didn't get any open wounds. That's my team's concern about me, is I get wounds, and I mean pretty big ones. The first time I had a PICC line, I was miserable at it. So what I did was, the people doing my PICC lines, I started to ask questions like, how do you get antibiotic into that when you flush it? I wanted to know how I'd get the cocaine in when I flush it. And I was really clean about it, like I used the clean syringes without the tip on the end. However, for those caught using drugs or perceived to be using during smoke breaks, there was a considerable amount of surveillance and disciplinary measures involved. As this nurse from Ottawa describes, we've got security that sits at their door 24/7. They just sit out of the room and they watch and make sure the patient doesn't leave the room. And using drug tests, psychiatric holds, and even calling the police to retrieve patients, all to ensure someone isn't using their PICC. Yet, a few care providers like this physician from Ottawa questions this, and the fear that someone will use their medical license or nursing license over this, and that elsewhere, this is treated as important, but that there were other ways of managing this. Yeah, the whole Ontario don't put a PICC line into a user kind of thing. I guess there's somebody that went to jail here, or some doctor lost their license. The first time I ever heard of this was when I came to Ontario. In their previous location, we used to put lines into people all the time. They used to leave AMA with lines. We would call the street nurses and say, hey, there's someone with a line in, they probably need to take it out to be safe. It wasn't a big deal. We didn't get the cops involved. Finally, there were some providers who disagreed with the idea that PICCs are themselves a source of infection and that they serve a harm reduction function, as this Toronto physician says. I think it's a harm reduction intervention. I hear that all the time. So-and-so has a PICC and they're going to leave AMA. What should I do? It's a clean site, it's been inserted by a professional, and rather than inject into that than into a dirty, extremity. So I think there's nothing wrong with it. I wouldn't insert it for the purpose of injecting, but if it happens to be there, I wouldn't, intentionally remove it out of fear of them using it for their addiction. Some of these providers share that they discussed the risk of injecting into a PICC line and how to do that in a safer way, as this second physician from Toronto adds that many of the issues associated with misusing PICCs can be addressed through on-site supervised consumption. And some bypass all of this through prescriptions, especially for opioids, that were professionally administered. So we're asking you to not inject into your PICC for safety reasons, and in exchange, we will provide you with an oral or IV opioids in addition to the antibiotics. In locating this with some recent literature, we know that a hospitalization is a critical moment for someone who might not even be aware of their HIV or hepatitis C status, and that the literature suggests this could be an opportunity to get them on HIV or hepatitis C treatment, and if relevant, opioid substitution treatment. Yet, what does threatening someone with arrest do to that relationship? The COVID-19 pandemic has profoundly impacted healthcare systems and people who use drugs, disruptions to drug supplies, reduce harm reduction and addiction services, and increase the risk of overdose infection. As well, we're seeing an increase in safer opioid prescribing, which is creating more space to think about how substance use, including injection drug use, can be integrated into mainstream healthcare. Because our data are pre-pandemic, we don't know about whether COVID protocols have impacted healthcare professionals' willingness to use PICCs and the current role, if any, of the kind of monitoring we've heard about. Additionally, we've been thinking a lot about how a more patient-centered approach, which recognizes that some people want to use their PICCs in this way and that others don't and won't, might be able to support patients to stay in the hospital or possibly allow for treatment in the community. We'd like to take a moment to acknowledge all of the participants for sharing their opinion with us. Thank you.